In our next scenario, we have a 22-year-old woman who presents to her OBGYN during her first pregnancy. At her first prenatal visit, early in her pregnancy, she asks what infections could put her baby at risk. There are a number of infections that can occur during pregnancy that put the fetus at risk, many of which can lead to neurologic deficits and other serious complications, as well as risk of fetal death. We use the acronym TORCH to help us remember some of the most important infections to consider. As outlined, these include toxoplasmosis, syphilis, varicella-zoster virus, parvovirus B19, rubella, cytomegalovirus, herpes simplex virus, and HIV. Almost all of these occur with transplacental spread of infection. We will discuss each of these infections with the exception of HIV, as full discussion of HIV extends beyond the scope of this lecture.
If we look at the microbiology of the torch infections, aside from one parasite, which is toxoplasmosis, and one bacteria, which is syphilis, the rest of the organisms are viruses. Of the viruses, there are 2 RNA viruses, rubella and HIV, with HIV having the special distinction of being a retrovirus. The rest of the torch infection viruses are DNA viruses. Of the DNA viruses, all are herpes viruses except parvovirus B19. Remember the happy mnemonic to recall which viruses are the DNA viruses. Toxoplasmosis is the first of the torch infections and is caused by the protozoan parasite Toxoplasma gondii. Cats are the definitive host, and the cyst form of the parasite is transmitted in their feces. Infection of people is through ingestion of directly contaminated food and drink, i.e. direct ingestion of the oocyst, or through ingestion of raw meat of animals that have been previously infected. Regardless of the infection method, the parasite, once ingested by a person, rapidly turns into the highly motile tachyzoite form. It is this form of the parasite that can spread transplacentally and cause congenital infection. During pregnancy, toxoplasmosis is usually asymptomatic, but when it is symptomatic, it typically results in a mild, non-specific febrile illness. One of the most common findings of infection in an immune-competent symptomatic individual is non-specific lymphadenopathy. In general, toxoplasmosis has a predilection to affect the central nervous system and the eyes, and thus these are the areas most often afflicted. Findings in congenital toxoplasmosis include the presence of chorioretinitis, seen here as a yellow lesion in this picture of the retina, intracranial calcifications present in this CT scan of the head, and hydrocephalus. Clinically, chorioretinitis can cause vision abnormalities, including painful and blurred vision. Neurologic sequelae in the infant include seizures, intellectual disability, and other types of central nervous system dysfunction. The risk and severity of infection seen in the fetus or infant depends on the gestational age of the pregnancy. Early in pregnancy, the risk of infection is lower, but the effects are much more severe, with outcomes such as stillbirth or severe neurologic ophthalmic disease the likely result.
Screening and diagnostic testing for toxoplasmosis typically includes serology with IgG and IgM antibodies. As a reminder, serology testing means assessing antibodies. Screening for toxoplasmosis at the beginning of pregnancy is not universally done. However, in areas where there's a high risk of highly virulent Toxoplasma gondii and increased risk of acquiring infection, such as in South America, prenatal screening is encouraged. The majority of patients with toxoplasmosis are asymptomatic. However, diagnostic testing with serology can be performed on pregnant patients if there are concerns of infection with toxoplasmosis, such as fever with adenopathy, or ultrasound findings concerning for congenital toxoplasmosis. When diagnosed with toxoplasmosis, whether symptomatic or asymptomatic, pregnant women are offered treatment to help protect the fetus. as treatment is unlikely to be needed for the benefit of the mother. Treatment options include the antiparasitic drugs spiromycin and pyrimethamine sulfadiazine. Neither of these medications are available commercially in the United States, and we will not go into them further at this time.
These next two slides give you a slightly expanded picture of congenital syphilis from what you received in MOD, but hopefully much of this is review. Congenital syphilis occurs as Treponema pallidum crosses the placenta and affects the fetus. Infants with congenital syphilis often present with nasal mucous membrane involvement within the first couple weeks of life, with associated nasal discharge called snuffles. Soon after, they develop a rash, which can involve the palms and soles, essentially the same findings that can be seen with secondary syphilis in adults. There are many other findings that can be seen in early congenital syphilis, including lymphadenopathy and hepatomegaly with jaundice. Many of the features of late congenital syphilis are similar to the findings seen in tertiary syphilis, including how it tends to affect the neurologic system and can cause gummas throughout the organs. Notably, sensorineural hearing loss often occurs as the eighth nerve is affected. The bones are often involved, with findings which include bowing of the tibias, termed saber shins, a depressed nasal bridge, termed saddle nose, and a prominent forehead, known as frontal bossing. The teeth are also frequently affected with a wide variety of changes, including central tooth notching, termed Hutchinson's teeth, and defective rounded rudimentary enamel cusps, termed mulberry molars. Eye involvement includes interstitial keratitis, which is inflammation of the corneal stroma.
All pregnant women should be screened for syphilis at their first prenatal visit. This can either be done with a non-treponemal test or a treponemal test. In individuals high risk for syphilis, screening is typically repeated between 28 and 32 weeks of pregnancy and again at delivery. As previously described, the primary treatment for syphilis is penicillin. Varicella-Zoster virus is in the family of herpes viruses, which are DNA viruses. It is spread through respiratory droplets or direct contact with active vesicles. Primary infection leads to varicella or chickenpox with key features including fever, malaise, and a diffuse vesicular rash in various stages of healing, often described as dewdrops on a rose petal. Varicella can lead to pneumonia, which is of special concern as it can be severe during pregnancy. The Varicella-Zoster virus remains latent in the sensory ganglia, the dorsal root being the most common but can occur in cranial nerve or autonomic ganglia. It can reactivate, spreading into peripheral nerves, leading to herpes zoster or shingles. This presents with groups of vesicles isolated to a single dermatome or along multiple contiguous dermatomes. The Varicella-Zoster virus does cross the placenta and can be transmitted from mother to child during maternal infection. Maternal varicella or chickenpox during early pregnancy, particularly between 8 and 20 weeks, does put the infant at risk for congenital varicella syndrome, a condition at birth with variable presentation but with features that can include limb hypoplasia and cicatricial skin lesions as depicted in this picture. Additionally, it can lead to neurologic and eye abnormalities. Congenital varicella syndrome, however, is rare and only occurs in about 2% of infants exposed to varicella in early pregnancy. Note that maternal herpes zoster does not appear to lead to congenital varicella syndrome. Additionally, an infant can contract varicella from a maternal peripartum infection either with varicella or herpes zoster. If there's a known peripartum exposure, the infant can be treated prophylactically with immunoglobulin against varicella-zoster virus. Due to their poor immunity, infants are at particular risk for severe or disseminated varicella, in which cases they should be treated with acyclovir. At the beginning of all pregnancies, immunity against varicella-zoster virus should be noted either with documentation of prior infection, prior vaccination, or serology. Serology testing for this is with IgG. It's important to note that IgG is the only antibody type that crosses the blood-placenta barrier. Pregnant patients that are not immune against the varicella-zoster virus are recommended to be vaccinated postpartum. As the vaccine is live attenuated, it is not safe during pregnancy. In the event that a non-immune pregnant patient has a significant exposure to the varicella-zoster virus, they may be considered to receive immune globulin to give passive immunity in effort to protect the fetus. If a pregnant patient develops varicella, treatment is with acyclovir, although it's unclear if acyclovir decreases transplacental transmission. Parvovirus B19 is responsible for the illness known as erythema infectiosum, or fifth disease, the classic pediatric febrile illness with rash, though it can occur in adults as well. The most classic feature of this is an erythematous malar rash called slapped cheek rash. Additionally, in certain cases, it can cause arthralgias. While parvovirus B19 is cytotoxic to erythroid progenitor cells, most healthy children and adults are unaffected from this standpoint, though it can cause aplastic crisis in individuals with underlying hematologic abnormalities, such as sickle cell disease. Although serology for parvo B19 is not routinely checked in pregnancy, prior infection in the mother, which is common, leads to immunity with IgG antibodies and fetal protection. Fetal loss, fetal anemia, and hydrops fetalis, which will be discussed further, can occur with maternal infection, with the greatest risk when the mother is infected during the first half of the pregnancy.
Parvoviridae are one of the smallest of the DNA viruses, and parvovirus B19 is one of the two parvoviridae known to cause disease in humans. The other one is the relatively obscure bocavirus, which can cause pediatric respiratory infections. Parvovirus B19 targets and has predilection for red blood cells. Although an infection in the mother is often asymptomatic or presents as a nonspecific flu-like illness, sometimes followed by a mild lace-like rash, it can have disastrous effects on the fetus. Specifically, it can kill erythrocyte precursors and cause severe anemia. The end result is high output congestive heart failure and hydrops fetalis, a fetal condition with a high risk of death characterized by fluid accumulation in serous cavities, such as in the peritoneal, pleural, or pericardial cavities. The pathophysiologic mechanism of hydrops fetalis is complex, but it seems that the high output cardiac heart failure causes increased venous pressure and lymphatic obstruction, which causes extravascular fluid to accumulate. Intrauterine blood transfusion may be necessary for fetal survival. Although parvovirus B19 is one of the principal causes of hydrops fetalis, it is not the only cause. For example, severe alpha thalassemia, a disorder in hemoglobin synthesis, can also cause it. Here we see an infant with a case of hydrops fetalis.
Rubella, or German measles, is a self-limiting mild febrile illness with associated rash. The typical rash begins on the face, then moves to the trunk and extremities in what is known as head-to-toe spread. It's typically erythematous and maculopapular. There can be associated lymphadenopathy and URI symptoms. Other classic features are Forsheimer spots, or red rose spots or petechia that appear on the soft palate before the rash. Maternal infection of rubella can be devastating with risk of fetal death or congenital defects, the greatest risk being if the infection occurs during the first half of the pregnancy. Particularly, infection during the first trimester may have up to 80 to 85% risk of fetal defects. Congenital rubella syndrome can affect multiple organs in an infant, but the classic findings are sensory-neural hearing loss, congenital heart disease, including patent ductus arteriosus, and cataracts. CNS involvement can be broad to include meningoencephalitis, microcephaly, and developmental delay. Additionally, both congenital rubella and CMV can lead to extramedullary hematopoiesis with dermal skin lesions in what is termed blueberry muffin baby. Standard prenatal care includes screening for immunity against rubella by checking IgG levels. Again, note that IgG antibodies are the only antibody type that can cross the blood-placenta barrier. Just like with the varicella vaccine, the MMR, measles, mumps, and rubella vaccine is a live attenuated vaccine and not safe in pregnancy. Non-immune pregnant patients should be immunized postpartum. Cytomegalovirus is the most common congenital viral infection and is the leading cause of non-hereditary sensory-neural hearing loss. CMV is a DNA herpes virus. As with other herpes viruses, CMV becomes latent after initial infection and can be reactivated. Additionally, a mother can be infected with a new strain of CMV. When a patient has a first episode of CMV, it's considered a primary infection. Whether a patient has a reactivation of latent infection or a new strain, it's considered non-primary. Infection with CMV is often asymptomatic. In fact, it's not clinically apparent in 90% of infected patients. When patients do have symptoms from CMV, it's usually with a mononucleosis-like infection, with fever, headache, and pharyngitis. Additionally, CMV can be responsible for elevation in liver enzymes.
One of the key features that can be seen in cells affected by cytomegalovirus is the presence of large purple basophilic inclusions, termed owl's eye inclusions. CMV typically affects endothelial and mesenchymal cells, where it produces this characteristic cytopathic effect. You should know this classic finding for your boards.
Fetuses can be infected if the mother has either a primary infection or non-primary infection of CMV. This differs from some of the other viral infections such as varicella, parvovirus B19, and rubella in that previous antibodies to CMV may not protect the fetus from infection. Only a small percentage of infants affected by CMV are symptomatic. Some of the pertinent features of congenital CMV include sensorineural hearing loss, CNS changes with intellectual disability, and chorioretinitis. A small percentage of symptomatic infants can have life-threatening illness such as sepsis. Of the approximately 90% of asymptomatic patients, about 10 to 15% will go on to develop sensorineural hearing loss while still young children, and that number increases to about 25% by adulthood. Eye abnormalities can also be delayed. Prenatal screening for CMV is not routinely performed, but testing for CMV with serologies with IgG and IgM can be performed if a patient is symptomatic. Reasons to test include a mononucleosis-like infection if Epstein-Barr virus is negative, or elevated liver tests but with negative hepatitis A, B, and C. Treatment for CMV is typically only supportive care. While most of the torch infections affect the fetus in utero, herpes simplex virus predominantly affects the infant through vertical transmission of HSV by direct contact at birth. Note that vertical transmission refers to passing of a pathogen from mother to baby either in utero or directly at birth. In case of HSV, transplacental spread is rare. Additionally, infants can be infected after birth, such as in the case of contact with an individual with cold sores. Neonatal HSV can be limited to the skin, eyes, and mouth, or it can be localized to the CNS with neonatal HSV meningoencephalitis. Most seriously, it can lead to disseminated disease with sepsis-like multi-organ damage. Acyclovir is particularly important for the treatment of a primary HSV infection during pregnancy. As recurrent infections are typically milder and self-limiting, some physicians and patients will choose not to treat every recurrent outbreak. Additionally, patients with a known history of genital herpes are typically treated with suppressive acyclovir after 36 weeks of pregnancy to decrease the risk of vertical spread. If there are active genital lesions present at delivery, C-section should be considered. All cases of neonatal HSV should be treated with acyclovir. In CNS or disseminated cases, additional supportive care is also recommended. You can see here we have a summary table of the different torch infections that we've covered. Now, while this is not 100% complete, hopefully it will be a helpful resource for you as you study. In this next scenario, we have a 24-year-old pregnant patient, G1P0, at 36 weeks gestation who presents to the clinic. She's had a healthy pregnancy up to this point. You instruct her that you will be testing for group B Streptococcus or GBS through a vaginal and rectal swab. As part of routine prenatal care, women will typically be screened for colonization with group B Strep at 35 to 37 weeks of their pregnancy. This is done through a swab first in the vagina and then the rectum, which is sent for GBS culture. If, however, the patient had a previous urine culture positive for GBS during her current pregnancy, a GBS screen at this time is not needed. Group B Streptococcus refers to Streptococcus agalactiae. While Group B Strep frequently colonizes the genitourinary and gastrointestinal tracts, often causing no harm, it's of specific concern in pregnancy and neonates. It can lead to maternal infections such as urinary tract infections, ranging from asymptomatic bacteriuria to pyelonephritis. Additionally, it can cause intraamniotic infection or chorioamnionitis, as well as postpartum endometritis and maternal bacteremia. Group B Strep becomes of extra concern to the neonate who can develop sepsis, meningitis, and/or pneumonia from GBS. Not only can this occur shortly after birth, but there can also be late-onset GBS infections up to 3 months after birth as well. Prolonged labor of greater than or equal to 18 hours after rupture of membranes is a risk factor for early onset neonatal GBS infection.
Like all streptococci, Streptococcus agalactiae, or group B Streptococcus, is a gram-positive cocci seen in chains. In general, it is beta hemolytic, which means on blood agar plate, it produces a ring of complete hemolysis around the areas of colony growth. It is classified as a group B Streptococci based on the Lancefield typing system, a system that categorizes streptococci based on the type of carbohydrate antigen chain present. Like Streptococcus pneumoniae, group B strep has a robust capsule which prevents it from being phagocytized by macrophages. For group B strep, a great mnemonic is to focus on the B. B for babies and B for beta hemolytic.
The main treatment for group B strep is with beta-lactam antibiotics, usually with penicillins or cephalosporins. While typically treatment of urinary tract infections in non-pregnant patients do not need follow-up urine culture or test of cure, pregnancy changes things. After treating a pregnant patient for UTI, it is recommended to recheck a urine culture to verify clearance. If a patient had a positive GBS screen at 35 to 37 weeks or a prior GBS infection during the current pregnancy, the patient should receive IV penicillin or ampicillin during labor to decrease the risk to the neonate. In the event of a penicillin allergy, clindamycin can be used. As our scenario continues, our patient delivers a healthy child via C-section. The delivery was complicated by the fact that she was GBS positive and had prolonged labor after rupture of membranes before finally going to C-section. 3 days postpartum, she starts having increased lower midline abdominal pain with fever. On exam, she has fever with a temperature of 103.2 Fahrenheit with a heart rate of 115. Her lower abdominal wall is moderately tender and she has malodorous, purulent lochia, or postpartum vaginal blood. This is a case of postpartum endometritis, or infection of the endometrium. This can occur postpartum with fever, uterine tenderness, tachycardia, midline lower abdominal pain. Notice there are a number of risk factors for postpartum endometritis, some of which are listed below. Specifically, C-section delivery increases the risk 10 to 30 times. Endometritis is often caused by multiple organisms or polymicrobial. Commonly involved organisms include aerobic as well as anaerobic bacteria. Among bacteria that can be involved include group A strep, group B strep, staph, genital mycoplasma organisms, among others. Of note, invasive group A strep infections, such as endometritis, can lead to streptococcal toxic shock syndrome, which is very similar to staphylococcal toxic shock syndrome that was previously discussed. Our treatment regimen for postpartum endometritis includes gentamicin plus clindamycin, one of our possible regimens for PID. Alternatively, you can use ampicillin with sulbactam. Ampicillin is a penicillin, beta-lactam, and when paired with the beta-lactamase inhibitor, sulbactam, it gives broad antibiotic coverage, including anaerobic coverage. Again, penicillin and other beta-lactams inhibit cell wall synthesis.
An intrauterine device, or IUD, is a birth control method which involves the insertion of a T-shaped foreign body device, which causes a sterile inflammatory reaction, which is toxic to sperm and egg and impairs implantation. If an IUD is left in place long enough, a possible complication which can result is actinomyces infection. Actinomyces is a filamentous, fungus-like bacteria which can colonize many different cavities, including the vagina, and cause opportunistic infection. Although infection is often low grade with vaginal discharge, it can ascend, involve the fallopian tubes and ovaries, and cause pelvic inflammatory disease type symptoms, especially pelvic pain, and rarely fever. Actinomyces forms tangled collections of mycelial fragments termed sulfur granules because they appear grossly yellow. Here we see such a collection of mycelial fragments surrounded by abundant acute inflammation. To the right, we see a case of ruptured actinomyces infection with readily identifiable sulfur granules.
Our patient has now recovered from endometritis and is at home with her baby. She is breastfeeding exclusively and has noticed some engorgement of her right breast over the last few days. Additionally, she has been struggling with sore and cracked nipples. Now, over the last 1 day, she's having fever with myalgias as well as increased pain and redness of the right breast. On exam, her right breast is engorged or swollen compared to the left. There is increased redness, warmth, and tenderness over the lateral right breast. Additionally, there are enlarged right axillary lymph nodes. Our patient has developed lactational mastitis, which is a breast infection associated with breastfeeding, most common in the first 3 months of breastfeeding. Mastitis typically occurs when engorgement from inadequate emptying of the breast leads to compression of mammary ducts and associated milk stasis. This can ultimately lead to bacterial infection. Cracked or damaged nipples from breastfeeding trauma increase the risk of mastitis. Signs and symptoms of mastitis include a red and painful swollen breast, often with fever and malaise. Sometimes the fever occurs prior to the redness of the breast. There also can be associated axillary lymphadenopathy. This can progress to a breast abscess that may need to be drained. Ultrasound can be used if there's concern for abscess. The most common causative organism is Staph aureus, though other bacteria can be involved and a culture of breast milk can be done if needed. Breastfeeding does not need to be stopped for mastitis. In fact, part of the treatment of mastitis is regularly emptying the breast completely, either through breastfeeding, pumping, or additionally with hand-expressing breast milk if needed. Antibiotic options to treat mastitis should be geared towards Staph aureus. Top options that cover MSSA well are typically cephalexin, a first-generation cephalosporin, and dicloxacillin, a penicillin. Amoxicillin clavulanate is also an excellent choice. If there's concern of MRSA, clindamycin and trimethoprim sulfamethoxazole would be good options, though trimethoprim sulfamethoxazole should not be used if breastfeeding an infant that is less than 1 month old. We will discuss amoxicillin clavulanate as well as trimethoprim sulfamethoxazole further, as we've not yet discussed these in detail.
In order to understand augmentin, you need to understand beta-lactamase enzymes. Certain bacteria produce these beta-lactamase enzymes, and this endows them with resistance to antibiotics. You can see that bacteria are streaked on the dishes with the white discs. Each disc is impregnated with a different antibiotic. Clear rings around the disc show that bacteria have not grown in these zones, indicating that these bacteria are not resistant to the antibiotic. In other words, they're susceptible. The bacteria on the right are susceptible to only 2 of the 7 antibiotics tested. You can see no rings or very small rings around 5, with 2 showing susceptibility. Penicillinase is a subtype of beta-lactamase enzyme. Bacteria expressing beta-lactamase enzymes remain sensitive to oxacillin. That's because this drug is resistant to degradation by this family of beta-lactamase enzymes. Bacteria that produce so-called ESBLs, or extended spectrum beta-lactamases, are multi-drug resistant strains. Beta-lactamase inhibitors are available, and when used in combination together with beta-lactam antibiotics, they extend beta-lactam spectrum of antibiotic activity to prevent antimicrobial resistance. 3 examples include clavulanic acid or clavulanate, sulfbactam, and tazobactam. By themselves, they have little to no antimicrobial properties. They can be combined with beta-lactam antibiotics. For example, the combination of amoxicillin and clavulanate is called augmentin. Together, they coordinately function to bind beta-lactamase enzymes more efficiently when compared with the beta-lactam antibiotic alone. Digging a little deeper into this combination, penicillins destroy bacteria after binding to penicillin-binding proteins. You can see here penicillin targeting bacteria. Penicillinases are enzymes produced by bacteria that destroy penicillins by cleaving the beta-lactam ring due to their active site's similarity to penicillin-binding proteins. Here you can see penicillinase having its effect, and the bacteria survive. Clavulanic acid, or clavulanate, is a decoy drug that enhances the activity of penicillins by binding to the active site of the penicillinase enzyme, thereby rendering that enzyme inactive. In the combination of amoxicillin and clavulanate, called augmentin, clavulanate inhibits the penicillinases. It's used for hospital-acquired pneumonias. Gram-negative and gram-positive coverage is achieved. Moreover, this drug covers beta-lactamase-producing organisms. It's delivered orally, unpleasant side effect of causing diarrhea, and it also has anaerobic coverage. Anti-metabolite antibiotics inhibit folic acid synthesis in bacteria. 2 folic acid synthesis inhibitors include sulfonamides and dihydrofolate reductase inhibitors. The 2 I'm referring to are sulfamethoxazole and trimethoprim. together called bactrim. Let's talk about bactrim's mechanism of action. In bacteria, nucleotide and DNA formation require tetrahydrofolate synthesis, and this synthetic pathway uses para-amino benzoic acid, also called PABA, as a beginning substrate. While this is required in bacteria, humans derive tetrahydrofolate totally from our diet. In other words, we have no Th4 biosynthetic pathway in our endogenous biochemistry. You can see the structural similarity between PABA and sulfonamides. Sulfamethoxazole mimics PABA to inhibit the first step in tetrahydrofolate synthesis, shown here. Trimethoprim blocks the last step in the synthesis of tetrahydrofolate, shown here. So the combination of sulfamethoxazole and trimethoprim, aka bactrim, acts synergistically to cover many gram-negative and gram-positive bacteria. However, there is no anaerobic coverage, while there is some protozoan coverage. This combination of sulfamethoxazole and trimethoprim, which you sometimes see as SMX-TMP, also called bactrim, has certain potential adverse effects in neonates. In particular, sulfamethoxazole demonstrates a frequent incidence of kernicterus. Sulfonamides are highly protein-bound to albumin. Sulfamethoxazole displaces bilirubin from its albumin binding sites in plasma, and when elevated levels of free plasma bilirubin occur, it crosses the blood-brain barrier to reach the central nervous system. Kernicterus results, and here's a definition for kernicterus. Hyperbilirubinemia that results from the displacement of bilirubin from albumin by sulfamethoxazole may cause bilirubin to accumulate in the gray matter of the central nervous system, potentially causing irreversible neurologic damage. Depending on the level of exposure, the effects range from clinically unnoticeable to severe brain damage and even death. There's a practice formative quiz in Canvas attached to this video that is linked to this learning module. You may take this quiz as many times as you wish. The questions in this quiz directly foreshadow the questions on the test for this course. Your answers on this quiz do not count towards your final grade. The rationales for the questions will appear to you after you get 4 out of 5 questions correct, and you may then progress to the subsequent learning module. Following the next learning module, you will encounter an additional quiz moving forward through this material.